Good afternoon, everyone, and welcome. My name is Amanda Coventry-Barrage, and I'm DWDC's Program Coordinator. Today, I'm joined by my colleague, Kelsey Goforth. Before we begin, I want to acknowledge that while we are meeting virtually, the land Dying with Dignity Canada is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Indigenous, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit, and we invite and encourage you to do your own research regarding the various treaties, in particular, the land in which you're meeting on while meeting with us today. I am thrilled to welcome you today to another one of our webinars where we aim to provide you with information and key takeaways on end-of-life topics alongside the professionals that know it best. And of course, this webinar is brought to you in celebration of Advanced Care Planning Month. So whether you're just getting started or need to update your Advanced Care Directive, Dying with Dignity Canada offers an Advanced Care Planning Kit for every province and territory on our website free of charge. We can also offer to send your kit in the post upon request. Okay, so before I welcome today's presenters, I'd like to go over a few housekeeping items. Everyone on the call today is muted. However, there will be opportunities to submit questions. To do so, please type your questions into the question bar on the Zoom side panel, and we will read it out for you at the end. Please try to keep your questions as concise and clear as possible. And while we are going to try to get to as many viewer questions as possible, unfortunately, we may not get to everyone. So if you have outstanding questions following the webinar or questions that are quite personal in nature, feel free to contact us at support@dyingwithdignity.ca, and we will follow up with you individually. And finally, we'll also be sending a post-webinar survey that will pop up on your screen after the webinar and will give you the opportunity to share your feedback. And also, please note that this session will be recorded, so there's no need for you to take notes if you don't want to. Okay, and now to introduce today's speakers. Welcome Dr. Heckman and Dr. Garland. Dr. Allan Garland received a Bachelor of Science from the University of Michigan and a Master of Arts from Harvard University. He completed his MD Internal Medicine residency and research, as well as clinical fellowship in pulmonary and critical care medicine at the University of Chicago. He also served in faculty positions at the Robert Wood Johnson Medical School in New Jersey, the Case Western Reserve University School of Medicine in Ohio, as well as served as the director of their medical intensive care units. He came to the University of Manitoba in 2007, where he serves as a professor of medicine and community health sciences, an adjunct scientist at the Manitoba Centre for Health Policy. Some of his research interests include epidemiology and long-term outcomes of critical illness, end-of-life care, disparities in ICU access, performance improvement, especially the relationships between clinical outcomes and ICU organization and structure, and finally, variation in medical practice and statistical modeling methods. Wow, that's quite the resume. I hope that you get some time to rest and relax in between all that work. And finally, we have Dr. George Heckman, who's joining us. Dr. Heckman holds an undergraduate degree in engineering physics from Laval University, as well as a Master of Mathematics and Computer Science from the University of Waterloo. In 1995, he graduated with a Doctor of Medicine from the University of Toronto, and he completed his residency training in internal medicine at the University of Toronto, as well as geriatric medicine at McMaster University. He's also a fellow of the Royal College of Physicians and Surgeons of Canada. He also completed a Master of Science degree in Health Research Methodology at McMaster University in 2006. Dr. Heckman has held the Schlegel Research Chair for Geriatric Medicine at the RIA since 2010 and is presently an Associate Professor with the School of Public Health Sciences at the University of Waterloo, as well as an Assistant Clinical Professor of Medicine at McMaster University. Research interests include the development of systems of care to better support persons living with frailty and chronic disease in primary care and long-term care, including a more proactive and frontline role for geriatric medicine specialists. Wow, both very qualified candidates joining us today. So thank you so much for both of you for joining us. Doctors Garland and Heckman were kind enough to prepare a presentation ahead of time on this research project. So we're going to pass the floor to them now.
All right, thank you. So I will load up my presentation. Sorry, I was just finishing up with a patient just now.
That's
Uh,
not a problem. Patients come first.
all right. So you're probably wondering, I guess, end of life geriatrician, that makes sense. End of life intensive care, that makes sense. Why is a geriatrician hanging out with an intensivist? That perhaps makes a bit less sense. I'm wondering what you can see right now. Are you able to see my presentation?
Yeah, I'm able to see your presentation. If you'd like, you can also set it to present mode.
Hoping I can do that. How's that? Is that better?
That's fantastic.
All right, perfect. And so some of this work has been funded by the Canadian Frailty Network, and we are very grateful to that initiative for funding a lot of work that we were able to conduct in a generally under-researched area, which is that of frailty and aging. And the Canadian Frailty Network did something that I wish other research funders would do, is they looked at different applications and tried to do some mixing and matching. And so they picked some intensive care applications, and they looked at ours, which was coming from a geriatric perspective, and said, you guys are going to get along. And we did. And we came up with a lot of good work, and we're going to present some of that work to you today, which was really focusing on an intervention study to look at whether we could improve end-of-life care outcomes for patients in long-term care homes. And we called it BABEL. And I'll explain why that is. But a lot of it has to do with the fact that people don't speak the same language in healthcare, and that leads to problems. And so can we harmonize the way we approach things? Our collaborators from the University of Waterloo, University of Calgary, Conestoga College, as well as University of Manitoba. And I'm listing all our intrepid collaborators and research coordinators. This was a very extensive, really challenging to do. And we can talk a little bit about the idea of doing research in the long-term care setting, but it needs to get done. So acknowledging Canadian Frailty Network for the main bulk of support for the grant, as well as Research Manitoba, and from my perspective, the Schlegel Research Chair in Geriatric Medicine, which allows me to have more time to do this kind of work. If you want to access the materials, we're going to be referring to some materials in the presentation, but all of the materials that we used and developed for the randomized trial are at the website for the Research Institute for Aging under resources/BABEL. And they're all there free. There's no paywall or anything like that. So we're going to talk a bit about the rationale for why we did this. This was a project where we deliberately sought out and engaged with people in the field quite broadly. We'll then discuss how this led to the framework for the intervention. We'll talk about the trial itself and the results, as well as some conclusions, and then open it up for discussion for this group. So yes, we're all going to die. And in healthcare, it seems to be something that we don't like to talk about, but we are going to talk about this. And the idea is, how are we going to die? Is it going to be on our own terms, or is it going to be something less on our own terms and potentially more problematic? So what we do know is that as people near the end of life, they receive tests, they receive more tests than usual, they receive more treatments, and often people wonder whether these treatments and tests are actually being helpful or whether they're being harmful. And we now do know there is a fair bit of evidence that shows that not only are these tests done and treatments offered with no actual improvement in the quality of life or the quality of death, but they may actually do harm or hasten things or prolong suffering. So we know that if you are in a long-term care home, where the length of, the expected life expectancy of a newly admitted long-term care resident in most of Canada is about 18 months to 24 months. Again, these people are nearing the end of life by and large. And if they are hospitalized, we do know that often they come back to the nursing home if they survive, more disabled, on more medications, with more skin problems, a lot of breakdown, and again, more medications, particularly antipsychotics, and it costs more. And so quality of life is worse and the costs are worse. And so, are we offering the right treatments and at the end of life? And this is a very common scenario put together by one of our colleagues, Dr. Paul Lebert, and it's based on a very common scenario from the hospital perspective. 3 a.m, an 80-year-old person in a congregate care setting falls going to the washroom, can't get up. 911 is called. They show up in the hospital. The emergency physician has no information except what he or she has in front of them, which is a thin person, somewhat incoherent, probably delirious, might be in fever, might be in shock, low blood pressure, and has an obviously fractured hip. So this person is very sick. And unless we know otherwise, the general approach is to do everything, right? And potentially a person who's delirious and in shock would require intensive care. And this is an example of what an intensive care unit might look like. And it might be fine for me, but is it fine for this 80-year-old person who's broken their hip in the middle of the night? So how do we know what this person would want? What would this person want if they were given enough information about their health status? If this person is delirious, who is going to speak on behalf of that person? And often we refer to this person as the substitute decision maker. Does this person have enough information to speak on the person's behalf? All too often, someone has been named a substitute decision maker. They might not even be aware of that. And all of a sudden, they're called upon to exercise this role, which is to speak on the behalf of a person, and they don't really know how that person would make their decision at the time. So it's a very challenging thing. And the common thread here is have we provided people with enough information about their health? And so advanced care planning aims to ensure that the care that a person gets near the end of their life is concordant and reflects what their wishes and goals would be, assuming they've been informed about what their health status is. And it's not a one-off conversation, but it's an ongoing conversation where we reflect. A person will reflect on the information, on their wishes, on their goals, in order for them to be able to formulate and communicate these wishes about future health and personal care. And in the setting of our gentleman who fell and has a broken hip in the setting of shock, ideally that person might have been identified as frail, and someone would have had a conversation with them about, well, what would we expect if you were this sick? What might happen to you? And how might we negotiate these conversations, make decisions for your health? So we know that advanced care planning in Canada in general remains suboptimal. We know that in the long-term care setting, this is a particular issue, with a lot of people still dying in hospital, being transferred to hospital near the end of life, having lots of tests and medications. We know that this is very variable across Canada. Some jurisdictions do somewhat better than others. And so with all this in mind, our goal with the BABEL investigators was to develop, implement, and evaluate an advanced care planning intervention with the aim of making it sustainable and scalable across the Canadian long-term care sector. And so we began by consulting, and we had a full-day workshop way back in 2017 in Toronto, and we flew in people or drove them in from the 3 provinces where the co-investigators are from. So Dr. Quayle in Alberta, Dr. Garland in Manitoba, and myself, and Drs. Keller and Buskart in Ontario. And we brought in a variety of people, including residents and families. We wish we would have had more, but it's hard for someone in long-term care to make the trip out So we were fortunate to get 4 people who had experience from the receiving end in long-term care. And we presented them with essentially a mock-up based on literature about what advanced care planning looks like, based on the literature. And we asked them to consider the different aspects, the different parts of the advanced care planning process, and discuss these in small groups and then bring back their conversations for the larger group in order for us to have a broad-based consultation and try to dig into what the barriers are, what the solutions might be, in order to develop an advanced care planning intervention that would be doable in all of these sectors. The key findings, and the paper is at that website, and it is free for download, is different provincial frameworks. And I saw a question in the Q&A earlier on about, I think, the Quebec framework, which reminded me of one of the key conundrums that we had. In Ontario, consent for any care decision has to be obtained at the moment that a decision must be made. You can't plan, you can't get an order for a certain procedure before it is required. And so locking in decisions ahead of time is forbidden in the Ontario context. Whereas in other jurisdictions, there was a blanket decision about capacity. And that decision could be reversed, but a person might be found either incapable of decisions about flu shots and chemotherapy and whatever, or fully capable for everything. So there was quite a significant spectrum of approaches across Canada that we wanted to try to negotiate. But we did find the shared weak links included lack of clarity on the identity and role of the substitute decision maker, the failure to share specific health-related information to a resident, to allow that person to contextualize their wishes. And I'll get to that within a specific example of what we mean. Often you'll find that in books, they will come up with hypothetical scenarios that say, well, what if your appendix, your gallbladder would have to come out? Would you want that or not? As a geriatrician in long-term care, I have not seen anyone's appendix need to be taken out in long-term care. So these scenarios are artificial and not relevant. A health crisis itself is a challenging time, and failure to communicate during the health crisis is a weak link. And by weak link, we mean leads to hospitalization in general. And physician involvement is highly variable. Some physicians are very highly involved and others are not. And then how do we make sure that this is an ongoing conversation? Most long-term care facilities in Canada have a case conference on admission within the first 6 to 8 weeks where they discuss DNR and all of these things, but often that's it. And it's not necessarily revisited, whereas it should. People get sicker, people get better, their wishes may change. So the substitute decision maker, and that's one of the important things, is the person who makes decisions on your behalf if you are not able to make them yourself. And we'll get into that. You can designate this person in a document called the power of attorney document. And if there's no power of attorney document, there generally is, depending on which province you live in, there's a hierarchy that the law specifies. So if you have a spouse, that person, if you have a spouse and no substitute decision maker identified, the spouse will automatically default to that person based on the law, and parents and children and siblings and other relatives and so on, depending on who's available. The implications were that the person, the resident, must always be asked first about whether they wish a treatment or not. And often that is not done, right? If the person is not capable to fully understand, then and only then should the substitute decision maker be approached. And that is how the law is defined in Ontario, not necessarily other places. But what we found in a lot of the work that we did is, regardless of where you were, the patient, the resident was generally skipped in terms of the conversation, and they would go straight to the substitute decision maker. Really, the person should always be asked. They may certainly be capable to make an informed choice at that time. And so based on that work, we developed the following principles for designing the intervention. And so the first principle was we need time to get to know the resident, and the resident needs time to get to know the long-term care team. And therefore, while we want to have a preliminary discussion soon after admission, we want to allow several weeks for this get to know period in order to fully proceed with a more broad conversation about care wishes. Second principle is optimally the physician should participate in the advanced care discussions. And we know full well from some of our work that this is at times challenging for the physicians. And so we made sure to designate the specific roles for the physicians in the BABEL discussions. In lieu of that, we guided the long-term care staff who would be at the conversations on what information they would seek out from physicians before the conversation. We also laid out that substitute decision makers and residents, even if partially capable or even if not, should participate in all advanced care planning discussions. And while a person with dementia may not fully grasp the complexities of a surgery or a chemotherapy, they can still, in many cases, tell us what matters to them, and that's critical. The focus on clear communication, wording was very critical. We were very careful with the wording, and we are revising it as we go. And again, allowing sufficient time. And so the full BABEL discussion beyond the introductory one should take on average about 60 minutes. Some people might be quicker, some people might take longer. We designed different topics to be addressed in a specified sequence. So obviously DNR and CPR is one of the important ones that needs to be done. And we start with that and then move along towards other conversations. We tried to design things to avoid technical, coercive, or negative terminology. One of the key fears in residents of long-term care homes was that the idea of do not treat meant don't treat my symptoms. And that is often how they interpret things. We laid out scripts to support communication, and we explained symptom control as an active intervention. We're not abandoning the resident if all we choose is to treat symptoms and stop treating the heart failure specifically. And we built in at each step measures to ensure that the team members seek out whether the resident or substitute decision maker are fully understanding what's being discussed. And so the main weak links are explicitly addressed, and we lay out in the workbook the importance of identifying the substitute decision maker, making sure that the SDM understands the role, which is to express the resident's wishes, not their own. Specifically discuss the philosophy of care. Do we want to do everything, or do we want to do nothing, or do we want something in the middle? Do we discuss the resident's wishes in the context of what's most likely to occur to them? Again, it's not the appendix. If someone has Parkinson's, it might be a fall or pneumonia. Talk about their preferred philosophy of care, inform them about their most likely health trajectory, and be honest and realistic about what's achievable in terms of goals of care. And finally, prepare the substitute decision makers intellectually and emotionally for medical emergencies, and reassure them that, let's say, when the rubber hits the road, that they're not going to be abandoned, they're going to be supported. So I talked about the idea of providing information specific to a person's health. And so consider persons with Parkinson's who has now started to choke on food, right? And what does that mean? And it's to guide the team members to understand that when someone with a neurological illness starts choking, that means that the condition has now arrived at a more advanced late stage, an end stage, so to speak. where the most likely complication is going to be pneumonia. Sometimes choking, but most of the time pneumonia. And then what does that mean? Well, we can give antibiotics to treat a pneumonia, but that's just going to treat the acute problem. It won't fix the choking, the aspiration. There's going to be another pneumonia. Now, do we give intensive care? In someone who's got advanced neurological disease, a breathing machine might become hard to remove. We can always put somebody on a breathing machine, but if they are frail, it is often hard to discontinue the breathing machine. And then we talk about what conditions there might be for a person to accept antibiotics or refuse them. We can basically tell them that antibiotics at the end of life are not necessarily indicated in all cases. And so we approach things from, again, what is most likely to happen to that person, and talk about the different things we might consider, but also whether these things would achieve outcomes, in particular, meaningful to their wishes. How do they interpret this information in terms of what matters to them the most? And finally, we make sure that assessment of resident capacity is integrated into this discussions. We really want people to engage with the residents. If the resident may not fully grasp all of these subtleties, that's fine, but at least they've been engaged and they have their chance to express their wishes. They can express what matters to them. And really, that's based on the principle of capacity, whereby someone with dementia may still agree to have a flu shot and be capable of doing so, but may not understand the idea of chemotherapy. And so, I'm sorry, Alan, I forgot to change back to your slides, but what I will do is I will turn it over to Dr. Garland now, and I can still navigate the slides, but I'll turn it over to Alan.
Well, you don't need to, George. If you can, I have my own
Okay.
version of the slides, so just stop
Okay.
sharing and then I'll start sharing.
Alrighty.
Okay, sounds good. All right. So I want to this down, that down, and that away. Hold on, I'm just clearing this out for myself. Okay, thank you, George. Okay, so I'm going to highlight a couple of things, a little bit of duplication, but also some differences. So with respect to nursing homes in Canada, there are 144,000 people in nursing homes. That was our focus here. It's 1 in 8 people over 75 years of age are residing in a nursing home in Canada. The majority have dementia. And 20% of all deaths in Canada occur in nursing homes. As George indicated, nursing home residents, their death is usually preceded by a great increase in the burden of severe symptoms. And people who are frail and in nursing homes are much more likely, when they get aggressive care, to have complications rather than benefit. We did a preliminary survey where we surveyed the healthcare workers about how advanced care planning works in 38 nursing homes in the 3 provinces. And the key points I want to point out to you are the things in green there. Residents participated, only 38% of nursing homes identified that residents usually participated in discussions. Now, granted, many nursing home residents have dementia, but also, very importantly, as George said, until the very end stages of dementia, that doesn't mean that they can't or shouldn't participate in these conversations. Also, disturbingly, only 61% of these nursing homes said that the physicians participated at a high level. That's problematic. And we asked them how good the adherence is in a medical crisis. When Mr. Jones, a nursing home resident, becomes acutely ill, how often are the decisions made that follow the previous advanced care planning decisions that were discussed? And it turns out it's not that high, and that's a concern as well. So, in addition, we recognized that in many places, this is true both in hospitals where I work and in nursing homes where George works, many discussions about advanced care planning solely seek to clarify what are called levels of care. Things like 3 levels. Should we do everything? Should we do nothing and just give comfort care? Or maybe an intermediate tier where we just we do everything except CPR. This very rough measuring tool of 3 gross levels really lacks the nuance regarding residents' wishes. Because what we found is that their wishes are much more nuanced than that simple categorization. We also found, and I was particularly surprised by this, that on nights and weekends, the way that many nursing home physicians work is that they share what we call cross coverage on nights and weekends, with some physicians covering hundreds of residents, some of whom they've never even met. So when something happens in the middle of the night or on a weekend, and that's the doctor, the cross covering doctor that gets called, they know nothing about the resident. And as a result, these decisions about what to do when something goes wrong, acutely wrong, somebody has acute shortness of breath or chest pain or something of that sort, the decision is often made just based on those 3 levels of care, basically on whether the patient has what we call a do not resuscitate status. Okay, now some of the principles, I want to highlight a couple of these that George mentioned already, but I like them, is that one of the principles of BABEL is that decisions should be based on what the resident wants and wishes, but within the context of what is medically achievable or what is realistic. Lastly, when we talk as health professionals, nurses, doctors, other people in nursing homes, or any medical setting, we need to use simple language and avoid medical jargon and medical abbreviations, because people generally don't understand those abbreviations and the jargon, but they don't ask. I want to highlight the thing George said about the role of the substitute decision makers. This is really important. And we, medical professionals, we contribute to this by asking the substitute decision maker the following question: what do you want us to do? I want to say that healthcare providers should never, ever ask a substitute decision maker that question, because it is legally, morally, and ethically the wrong question. In addition, when you ask a loved one that question, they try to answer that question, but that's not the right question. And asking it that way puts a huge emotional burden on them compared to asking the right question. What do you think your loved one would want us to do in the current situation? If you ask that question, the substitute decision maker tries to answer that, and it is the right question, and it is less full of emotional burden. The 5 elements of the BABEL discussion done in this order are: ensure the substitute decision maker understands and accepts their role, prepare the substitute decision maker emotionally and intellectually for medical emergencies. Because even though one of the things that we know is that it is not uncommon, in fact, it's quite common, that a decision is made in the light of day when everything's calm and the resident or nursing home resident is not critically ill or acutely ill. The decision is made to be more conservative in what we would do if things got bad. But then something bad happens. A person develops chest pain or has evidence of a stroke or something, and the substitute decision maker gets called at 3 a.m. and they panic because they haven't been prepared emotionally and intellectually to deal with this reality. Next, clarify the resident's true medical situation, what we call the prognosis, and explain the alternative philosophical approaches to care that exist. And then discuss the specific things that person is likely to have happen to them, not hypotheticals that are not likely in that person, but the things that person is likely to experience in the context of number 3 and number 4. So George gave the example of somebody with advanced Parkinson's disease developing problems swallowing, and as a result, choking on their food and having breathing problems. Well, people with Parkinson's disease, we know that that is eventually going to happen. And so that's an example of something we should discuss in such people. But we don't need to discuss that eventuality in the case of other people who don't have swallowing problems and whose underlying disorders are not likely to cause swallowing problems. Okay, so discussing the specific medical options. I'm going to skip that. Let's see. Yes, I'm going to skip that. Okay, now I'm going to talk about the study. We did this study. Cluster randomized means this. We recruited 29 nursing homes in 3 provinces, and we randomized them by a flip of a coin to you're in Group A or Group B. And Group A, we trained them and asked them to do advanced care planning discussions according to the BABEL approach. And in the other group, we asked them to do advanced care planning discussions the way that they usually did, whatever that was. Okay, so we call them intervention and control. The residents were included if they were 65 or older. They or their substitute decision maker gave consent to participate, and they had the presence of any of 4 particular risk factors that are known to be associated with a higher risk of death within the next 6 months. Those were things like cancer, congestive heart failure, and a few other things. We train in the intervention homes, the homes that agreed to do advanced care planning according to the BABEL approach. We trained everybody. We had a 1-hour session in person delivered to all staff on all 3 shifts. So we went in even in the middle of the night to do the night shift, to train the night shift. We talked to them. We gave them a talk like this. We did some pre-recorded audio role playing, and we gave them the BABEL workbook that contains the scripts that George mentioned, which are really just a way to express things that have been found to be particularly useful and helpful, and the knowledge products, which were pamphlets and other things about end-of-life care and advanced care planning. We had 12 outcomes. The main 2 outcomes were these 2. First was a measure of the comprehensiveness of advanced care planning. What we did is we used a tool where we asked residents, or mostly their substitute decision makers, to tell us, to identify the elements of advanced care planning that had been discussed in the advanced care planning discussions. And that comes up with a measure that's scored on a 0 to 7 scale of how comprehensive the discussion about advanced care planning was. The second was a measure, a tool, a measure filled out by the resident's main nurse during that each resident who died. We had the main nurse who was taking care of that resident in the final week of life, identify any struggles or symptoms that the resident had. And this leads to a score that goes from 3 to 42 called comfort in dying. Those were the main 2 outcomes, but we had 10 others. We looked at the rate of courses of antibiotics given in the nursing home, the rate of other interventions, both in the nursing home and outside the nursing home, everything except antibiotics. We looked at the rate of transfer of nursing home residents to emergency or hospital, the rate of admission to intensive care units, the rate of death, and the rate of transition to palliative care. We also, for the residents who were with it enough to complete it, we asked the residents themselves 6 weeks after the study began, after they were entered into the study, how they felt about advanced care planning. We asked the substitute decision makers of the residents in the study who died during the study. We asked them their satisfaction with the care of their loved one at the end of life. And we asked a single question of the substitute decision makers: was the plan of care that was decided on during the advanced care planning discussion, what was actually done? Okay, so those were the 12 outcomes. We had 713 total residents included in the study, more in the control group than in the intervention group. And the reason for this is that we actually expected to have 1,150 patients or residents, but the refusals were twice what we anticipated. And in addition, we were limited by the fact that we started this in 2017, 18, and then 19, and then COVID began. And by May of 2020, the COVID pandemic severely limited our ability to even enter nursing homes in Canada. So we needed to stop recruitment. So we didn't get as many subjects, residents, into our study as we hoped. Nonetheless, here's what we had. The resident average age was 88. We know that residents in Canadian nursing homes are quite, on average, are quite old. About a quarter were married and most were female, and that's because women outlive men in our society. There were 29 nursing homes, as you can see. The average number of beds in each nursing home was about 140, and about a little less than half were publicly owned. Okay. So this slide and the one after it are pretty technical. I will explain it to you. These are the two main outcomes that we looked at. And I don't expect you to really, I'm not going to explain in great detail what effect size means. I'm going to say that the ones in green suggest that there is a difference between the two types of homes in that measure. And the ones in yellow indicate that that seems to be what we call statistically significant. So what the comprehensiveness of advanced care planning measure tells us here is that in the homes in which the advanced care planning was done according to the BABEL concept, the rating of the comprehensiveness of advanced care planning was much higher than in the homes in which they did advanced care planning in their usual way. The comfort assessment in dying was not different. Here's the other outcomes, and I won't go through all of them one by one. I will highlight that in the homes that did ACP according to the BABEL approach, there was less use of antibiotics. That's what the green and the yellow there mean. Less use of fewer courses of antibiotics in those nursing homes. And although it did not reach what we call statistical significance, there were fewer people in BABEL homes who were transferred to hospital or emergency or admitted to intensive care unit. There was higher resident self-efficacy, which really means how the residents themselves felt about advanced care planning and their understanding of it. And there was greater agreement that the plan of care was followed amongst the people who had died. Okay, we did one other thing. We interviewed in each nursing home, all 29 of them, one staff member who was the most involved in advanced care planning discussions. And we asked them, we had a conversation with them, and we got from them these themes. That in the BABEL homes, the people who were actually having the BABEL discussions, which were by and large nurses and social workers, they felt that the BABEL approach made them more informed, improved their confidence, improved the clarity and focus of the conversations they had with the residents and their family members. It led to residents and substitute decision makers, families who were better informed, and it improved what was written in the chart about what residents wanted with respect to advanced care planning at the end of life. The main difficulty with BABEL that we actually anticipated was it takes a long time. It takes a substantial amount of time to have these discussions and be comprehensive. If you're trying to talk about everything that's relevant, you have to give it time to talk about everything that's relevant. And when you don't give it enough time, which is about an hour or so, then you end up with important aspects of advanced care planning that have not been covered, that have not been discussed. And therefore, what actually happens when a nursing home resident becomes acutely ill may not be what the resident wanted. The other main finding of this interviews with the people in the nursing homes, the nurses mainly, who had the advanced care planning discussions with the residents, was that, as we had shown before the study, there was relatively low physician involvement in these conversations. Okay, so some summary. BABEL ACP results in more comprehensive discussions, decreased use of antibiotics. And other uses of resources, medical resources like transfers to hospitals and emergency rooms may be lower as well. The major barrier is the time needed to do it. And this problem may be getting worse because there's a growing shortage of nursing home staff. So there's fewer people to go around, staff members to go around in nursing homes now. And this problem is increasing in intensity. We also conclude that advanced care planning in nursing homes needs to be much more nuanced than just do everything or do nothing or everything except CPR. These findings underscore the importance of allowing adequate time for ACP discussions. We think that a first ACP discussion takes an hour. And we do not believe that shortcuts that compromise quality of ACP are likely to be found. I'm sorry, shortcuts that don't compromise the quality and comprehensiveness of advanced care planning are likely to be found. We think that in this human endeavor, time is needed to have these fulsome and important discussions and address all of the relevant issues for each resident, which are different for each resident, by the way, as we've mentioned, and that we're not likely to find magic shortcuts that will shorten the time necessary. Now, professional societies of doctors, nurses, have created what we call core competencies for nursing home nurses and physicians. However, these competencies are not mandated anywhere that we know of. We believe that advanced care planning should be recognized as a core competency of people who work in nursing homes or take care of people who work in or take care of nursing home residents. So we think that it is necessary to rethink all of how nursing homes are organized and how people are trained to work in them. We even wonder whether nursing home medicine should be a specialty itself. So Dr. Heckman is a geriatrician, that's a specialty. But that's a specialty which has to do with the care of older people. It is not even more subspecialized of the care of people in nursing homes. Should there be specialized training? Should there be what we call board examinations where you have to be certified in nursing home medicine? Maybe. Nursing home physicians almost exclusively have outpatient practices. So they go to the nursing home for a period each day or a few times a week, sometimes every day, sometimes not. And they see the patients there, but they almost always have other things pulling them in other directions. And those other things are outpatient practices. And they may even see people in the hospital. So here's a question. Should nursing home physician work be such that nursing home physicians hang out in the nursing home all day? That's what they do. So I'm an intensive care unit physician, and for decades now, the recognition was in care of the critically ill patient is that that there should be somebody, a specialist like me, for instance, in the care of critically ill people who hangs out in the ICU all day long. Should that be the same for nursing home physicians? Should there be teams of specialized people whose job within nursing homes is to be highly expert at having these conversations, and they're the ones that have these conversations with all the residents and their loved ones about advanced care planning decisions? So that's it. We talked about the design and concepts of BABEL, which if that wasn't clear, we're happy to answer questions. We talked about the research study itself, which I gave you the results of, and it's now about 10:02. So we have about 25 minutes, according to Amanda, to have questions.
Yes, absolutely. And thank you so much, Dr. Garland and Dr. Heckman, for those wonderful presentations. And as I mentioned before, we have lots of questions from our audience members. So thank you so much to our audience. So what I'll do is I'll pose a question, and then Dr. Garland or Dr. Heckman, feel free to jump in or add after one speaker has gone, and then we'll get started. Okay, so our first question from our audience member is, if you have no immediate options for an advocate or a substitute decision maker, for example, a spouse or a child, or a younger friend or colleague, how do you ensure that your wishes are carried out?
George?
I think in Ontario, I speak for Ontario. I suspect there's a similar mechanism. I think there's always a office of the public guardian and trustee. So there's an ombudsperson who is generally available for persons who may have challenges in expressing their opinions and expressing their wishes. And usually they come on board when someone is incapable. So it's a bit late in the game. If you are a person who does not have family necessarily, I think that's a gap. It could be a friend. You could nominate a friend. You can nominate anyone. I mean, the law will allow you to do that. I think having, especially in a primary care setting, if you can get access to a social work, or maybe even, I suppose the Dying with Dignity will offer this kind of advice for people. I think it's always helpful to find someone who's willing to listen and to understand, what your values are. Really, this is a conversation about values and wishes. And in order for you to exercise your right to express those wishes and values, you require information and the proper information. So there are probably different remedies. I think the main risk is that the person is not talked to, even if they have dementia, and that their wishes are ignored. I once saw a person who had dementia, who was facing either open heart surgery, or a very complicated stent from which he could not recover. And half the family wanted surgery, half the family wanted the stent. And I elected to make this crazy decision, and I went to speak to the person because no one else had. And he said, I want the thing that protects my brain the most. And that was the stent. And so that's what happened. So always talk to the person.
Let me make a comment about public trustees. If you literally have no one, and it doesn't have to be a relative, as George said, it could be just a friend. If you literally have no one, the only one, the legal person would be the public trustee, which means something has to happen in the courts to assign that person. The public trustees are not brave. They usually err on the side of do everything. So no matter who you have, whether it's a public trustee, whether it's your spouse, whether it's a friend, the most important thing is you need to explain to them what your limits are, so that when the time comes and you can no longer express them, they can express them for you. That's the most important thing. I'm always amazed. So again, I work in the intensive care unit. I'm always amazed when I sit down with a wife of a patient who's the husband, say, and they've been married for 50 years. And I ask, well, have you ever talked about what you would or would not want when things got real bad with you medically? And people who've been married for 50 years say, no, we've never discussed it. You have to discuss it with your loved ones.
Thank you so much for both of your answers. And maybe just as a follow-up question to both of you, could it be helpful for individuals in this circumstance to talk with their primary care provider about the fact that they may not have anybody who could qualify as an SDM?
Anyone can qualify as an SDM. You just have to assign them. Even your physician could be your SDM if you put it in writing.
Thank you so much for that. All right, so for our next question, our audience member asks, do I need to talk to my family doctor or primary care provider to get started on advanced care planning?
Well, not necessarily. I think as Allan just said, think about speaking to your spouse. And this is an ongoing conversation. I think in our society these days, we want something written down, pinned down, and we want to basically put it in our safety deposit box and never see it again. That's the wrong way to do it. You do not necessarily have to arrive at the same conclusion each time. As your health changes, you may change your perspectives. The idea is to start talking about it. I think making sure that the family doctor knows who your substitute decision maker is going to be very important, because you may end up being hit by a car and unconscious, and something may happen, and then we don't know what to do. But I think just start and loop in the family. You may pick one person as substitute decision maker, but if you loop in more people, then you reduce the risk of arguments at the end of life, and keep your family doctor aware of things.
Absolutely. Thank you for that. And as a follow-up question to that, specifically on the subject of family, our audience member asks, what do you do if your family goes against your wishes in the end?
That's a very complicated issue. So if, first of all, who would know? It's important that people know what you would or would not want. When this happened, I'll tell you what the legal answer is. The legal answer is substitute decision makers are surrogates by definition. And so when a clinician, a physician, or a nurse practitioner knows for a fact that the substitute decision maker is making a decision that is against the wishes of the resident, of the patient, then that person is no longer acting as a surrogate, and they are no longer an appropriate substitute decision maker. Legally, you'd have to go to court and have them removed. And practically, we never do that. Practically, what I do in the intensive care unit setting is get more people who can speak to what the patient wants, what they don't want, and get everybody on the same page around what the patient wants, and let's do that. But it can be very difficult because if there's only, let's say there's an elderly husband and wife, and one is the SDM for the other, and there's nobody else, how would the team know? So the answer is choose your SDM wisely. Make sure they're willing to do what you want done. And if they're not willing to do what you want done, choose a different SDM.
Thank you, Dr. Garland. And I think that also emphasizes the importance of having these conversations before you get into moments of crisis.
Of course.
Okay, thank you for that answer. Our next question, let's see here. So regarding problems, including patients and families in the consultation process, can they not participate using video conferencing software like Zoom these days?
George?
I think that's reasonable. Doing things in person in many ways is helpful. I like to demonstrate certain things and point things out physically, and sometimes that's hard to do virtually, but it's not uncommon that a person in a retirement home or nursing home has a substitute decision maker. We have one who's in Australia, and that's made things fairly challenging. So we have no choice but to do it virtually. I think the principles of BABEL, I think, are fairly universal. Is you provide an honest assessment, honest and objective assessment of a person's health and what they might expect. And we took the story about Parkinson's, but you can talk about dialysis, right? Starting dialysis, if you're a long-term care resident, does not improve your quality of life whatsoever and might make it worse. And you can tell that to someone and they may say, well, my principles are that I want to do dialysis, and others might say, really? I thought it would make me feel a lot better. If it's not, then forget it. But I think that's the key bit. And once you provide them with that information, generally they feel free. And so there's nothing that precludes you from doing it virtually if you have to.
Thank you for that. Dr. Garland, was there anything else to add, or?
No, I frequently had in the acute setting, in the intensive care unit, usually the time is often too short from the person from BC to fly in. And so it is not uncommon to get the children who are here be in person, and at the same time have the kid in BC on the phone. It's better than excluding them. It's not optimal, as George says, but it's better than excluding them.
Absolutely. Thank you. All right. For our next question, our audience member has a bit of difficulty with this. So they ask, my family members are resistant to talking about advanced care planning. Do you have any tips for how to start that conversation?
I tell people this. I tell people, think about it. I talk to substitute decision makers like this. Your time will come. And when your time comes, you will want your loved ones to know what you want and tell the team what you want so that you get what you want. This is just the same. Instead of it being your time now, it's my time now, and so I want to discuss it with you. But you're going to want, the only way I can get what I want And the only way you're going to be able to get what you want when your time comes is to make sure that the loved ones know the answer to that. So I think that that often helps substitute decision makers understand their role as the substitute decision maker. But I also think it might help in this particular case as well. But the bottom line is, if you can't get the people who should be your SDM to talk about realistically about the fact that you're not going to live forever, you probably need to find another SDM.
Thank you so much. Dr. Heckman, was there anything else to add?
No, I think that's correct. If some people will not want to talk about it, and I think there's ways to facilitate the conversation. But ultimately, if they really don't want to talk about it, you don't have to be an SDM. It is not a legal obligation to accept that role, but it means that you have to find somebody else.
Sometimes that somebody else is not the spouse. Sometimes it's the person who really knows the wishes, I found, is the lifetime best friend, or sometimes the clergy member. Sometimes it's not the next of kin.
Absolutely. Thank you for that. And we had a similar question actually from an audience member. Can I designate my child even if my spouse is living? And I think you touched on that a little bit.
Yeah.
Yeah. Thank you so much. All right. So
but let me just say,
yeah.
You do want to avoid conflict when the time comes. So what I do in the case of the kind of situation George mentioned earlier, where you have different family members, sometimes large families who disagree vehemently, is get everybody around the table. Instead of isolating the single substitute decision maker from their own support system, I get everybody together around the same table and make clear that what our goal is to find out what the person would want and do that. And I find that the substitute decision maker who is resistant often comes around when others say, this is a common example, I've experienced it numerous times, is the spouse says, well, I'm not so sure, he's sort of a fighter, maybe he would want everything. But the kids go, come on, mom, you know he wouldn't want this. I found that's very powerful.
Absolutely. And again, the importance of conversations highlighted. And so for our next question, an audience member would just like to have a reminder. Can you remind us, please, what does BABEL stand for?
Better assess.
It's on your first slide. It's on your first slide, George.
Better targeting. Let me just. It's not actually.
It's not.
We came up with this, and I'll find it for you as soon as I can.
Okay, thank you.
It's one of those acronyms that it is not the first letter of each word. We sort of chose the acronym and then found the letters within the words to represent it. So yeah, it's not one of those easy acronyms.
That's okay. We'll circle back to it. All right. Actually, I just have a note here. So it stands for better targeting, better outcomes for frail elderly patients.
Yes.
Right.
There we go.
Thank you, Kelsey.
We got to it. Thank you, Kelsey, for that note. Okay, so for my next question, Dr. Heckman, I believe, you mentioned in your presentation that tests and treatments near the end of life may cause harm.
Mm-hmm.
Why do you think that this is still a relatively common practice?
It's easier, right? And so think about how our healthcare system has been set up. It was set up in the 1950s in Saskatchewan because people had injuries, farmers, workers, and if you know, that's what that was the nature of healthcare needs back then. And so we still have a system that is focused on hospitals. If you call a family doctor office sometimes on a Friday at 3 o'clock, the office is closed. If this is an emergency, go to your nearest emergency room. And so everything is in a way designed to funnel you towards the emergency room, right? Which is do more, do more, do more. Often it is easier to just throw your hands up and say, fine, we'll send you to the hospital. Fine, we'll do this. Part of that I would hypothesize, and I think based on some of the work that we've done, is our healthcare system does not reward people, does not provide them with the time to actually do these conversations. And so an advanced care planning conversation for a family doctor would basically be a minor assessment, which is $35. And if you're a family doctor and have to run a business, which is what they do, you just don't, right? And so that is one of the barriers. Another barrier is we don't teach this stuff very well. You know, as we found out in our work, people were having challenges. There were lots of barriers, and some of them were related to education, which is why we developed a lot of educational materials. And so again, we have a system which is, you know, shoot first, ask questions later, to paraphrase the expression, as opposed to hold on, let's talk.
Yeah, absolutely. Thank you for that. Dr. Garland, did you want anything to add for that? No?
No.
Okay. Fantastic. Thank you for that. For our next question, our audience member asks, should advanced care planning not be done for everyone, not just nursing home residents?
Yeah, the answer is simple, yes. And it should also be done for people who aren't elderly, because bad things happen more rarely, but they do happen to young people. So everybody, in principle, should have their loved ones know what their limits are. And it's okay if your limits change. This is really important, because what we're willing to live with changes through the course of our life. And also not just changes with age, but what we've gone through. People who've been through more medical things might be more willing to have more medical things than somebody who hasn't been through them. So it's perfectly okay to change your mind or to evolve over time. And so your SDM needs to be somebody not who you talk to once in your life, but that you're constantly in contact with and knows how you think and knows your philosophy of life and death. So, but the answer to that question is clearly yes. George does a lot of work in the kinds of what do they call, George? The kind of places people live before they're in nursing homes, assisted living,
Yeah,
or assisted living, and that would be an important place because there's a clear pathway from assisted living to nursing homes. The problem is the number of trained staff members in assisted living per resident is even fewer than in nursing homes. So there's even less body of people to have these hour-long conversations than there is in nursing homes. So, but the answer is absolutely yes.
Thank you for that, Dr. Garland. Okay, we have just 5 minutes left. How the time flies. So we're going to wrap up with a few more questions. So we'd like to ask, has there been any new developments with long-term care homes and the BABEL approach since you originally had published your research?
George?
I unfortunately no. And I think it's interesting because what's happened, at least in Ontario, and I suspect it's the entire country, is nurses are quitting in droves. And we had, before BABEL, we had a human resource problem that made it hard for this to get done. And it's even worse. And so it's been quite challenging. We also have a system where ministries of health will focus on certain problems that they consider to be critical. And this year in Ontario, it is skin problems. And so everyone has to, the tail wags the dog in Ontario, and it's probably the same way around the rest of the country. And so we have a very odd system where, again, it's reactive. But I think, as Dr. Garland mentioned, I think we really need to think hard about the physician's role and training and certification. We need to think about that hard from the perspective of nurses. And someone raised a comment about nurse practitioners in long-term care, which I think are an ideal mix of skills, which include the diagnostics and the prescribing, but also the nursing approach and the teaching and conversation. So I think right now it's a bad, funny time in long-term care. And I think we do have a healthcare system that does not favor important structural changes, but rather, little things here and there, and not a big picture approach.
Yeah, thank you. And that's certainly unfortunate to hear, and we hope that that situation will improve, not just for residents, but also for healthcare practitioners as well. Okay, so for our next question, our audience member asks, as a community resident, how can I increase the likelihood that my advanced care plan will be respected by emergency room and healthcare staff in the event of a healthcare crisis?
Yeah, this is a serious issue that we address because we found out that often doesn't happen. Some emergency rooms are to blame for this because some emergency rooms won't take a person from a nursing home in transfer unless they've agreed to be unless they have rescinded their do not resuscitate. But this is completely unfair. You should be allowed to say, I don't want heroic efforts like resuscitation if my heart or breathing stops. And yet, if I have a cut, I want it to be sewn up. If I have a broken bone, I want to have a cast. So this is a multifactorial problem that's not easy. You need to talk to the people in the nursing home about that. You need to make sure that whatever you wished for is written in the notes and transferred to the hospital with you. This is not an easy answer. George, do you have anything more to say?
No, I think that's part of the conversation. The emergency rooms often, I mean, what I've been trying to do myself is that if I have to send a resident to a hospital, I call them myself and explain the situation because again, structurally the transfers are poorly done, and I make my perspective known. This person has a broken wrist. Please fix it. Send them back. I'll look after them. Don't worry about it. And from that perspective, they're happy with that. I think it's critical that a long-term care home not send someone to the hospital without checking the substitute decision maker. Often that happens, right? It starts there. The transfer happens before you're told. The person arrives in the emergency room. We don't know anything. You haven't been told. The emergency room people will do what they do, which is the default, which is everything. And so I think it's to be clear as an advocate, as a substitute decision maker, thou shalt not transfer anyone without calling me. And it starts from there.
Thank you for that. I would also say it sounds like there's lots of room for improvement with respect to increase in the amount of healthcare staff that are available, the increase in hours allotted to have these conversations, but also as well to sort of increase the quality of that transfer. So thank you both.
Some of it is the machine. Let me just make one more comment about that. Some of it's the machinery. So for instance, there needs to be in nursing homes a system to identify what the resident wants, what their advanced care plan is, and make sure that it's written someplace prominent so that it goes to the emergency room and is prominently seen as soon as they get to the emergency room. Otherwise, it's likely to be missed. If it's buried in 300 pages of progress notes, they're not going to find it. There needs to be a machinery built that ensures that this very important piece of paper goes with them and everyone's aware of it.
Absolutely. All right, time flies. We are just at 4:16 p.m. Eastern, and unfortunately we are now out of time. I want to thank all of our audience members for submitting your questions. And again, if there's any follow-up that you'd like, you can always feel free to reach us out at support@dyingwithdignity.ca. Thank you so much, Dr. Garland, Dr. Heckman, for your presentation, for your participation, and for your wonderful contributions today. We did receive multiple love notes from our audience members, one of them saying this was a phenomenal presentation. Thank you so much to both speakers. So just know that our audience was very grateful for your time today.
Thank you. Our pleasure.
Thank you for the opportunity.
Of course, of course. And thank you everybody for joining us today. We will have a recording available on our website in approximately a week's time. And thank you so much for joining us today, and please take care.
Amanda, can you make sure that the RIA website address that has all the materials for BABEL on it, freely available, is made available to all of your all the people who are here today?
Absolutely, we would be delighted. So everybody, you will receive that follow-up recording as well as all of the relevant materials from BABEL so that you can also get started on your advanced care plan. Thank you, everybody, and enjoy the rest of your day.
Thanks.
Bye-bye.